So let's just now compare the phonocardiograph briefly with the electrocardiogram. Okay? The electrocardiogram, or EEG, is something which we hear about a lot. And the electrocardiogram is not something which shows us the sounds of the heart, it shows the electricity of the heart. So what happens here, if we go back to our first picture of this, with our heart sounds. Here's our phonocardiograph. Our first sound, is the phonocardiograph. First sound, second sound, first sound, second sound. First sound is contraction or systole between the first and the second sound, and then rest or diastole, and so on. So electrically, we get a spike of electrical activity around the first one, as you'd imagine, as the charge goes down, and then we get another little peak here just before the second sound, and then it repeats itself. Now, each of these little electrical patterns has a number to it, and they're numbered for some reason P, Q, R, S, T, U. So the electrocardiogram schematic representation of a normal rhythm, electrical rhythm, which is called sinus rhythm, showing the standard waves. So we have P to Q to R to S to T. Okay? So each one of these has an interval, and this is what they measure critically with the electrocardiograph, is within limits of whether that electrical activity is correct. If it's not, it's abnormal. So they measure the time of P to R, P to R working here, QRS complex here, the ST, and most important is the QT interval. So we said about that, while there is a significant range within which variations in rhythm are considered normal, anything that deviates from the normal rhythm by more than a certain amount in time-wise may be indicative of heart disease. The cardiac conduction, or genetic system, is a pathway that consists of specialized cells known as myocytes, or cardiac cells, which create the natural electrical impulse. The location within the conduction system that gives rise to electrical impulse is known as the pacemaker, and as we learnt, the major pacemaker is the s.a.node. So here we see the myocyte cells, specialized cells in just the heart, which initiate this electrical conduction. From the s.a.node, we know that it goes through to the AV. The electrical impulse spreads through the interatrial tracts that spread electrical impulses through the right and left atrium, and therefore cause atrial depolarization, and this is known as a P wave. So after the atrial depolarization, the electrical impulse spreads through the internodal tracts and reaches the AV node. The AV node has its own pacing rhythm that serves as a backup, even though it's slower. So again, okay, so we know that it goes through to the Purkinje. Sinus rhythm, commonly referred to as normal sinus rhythm, is designated as the normal rhythm of the heart. Several requirements must be met for an electrocardiograph to be classified as normal sinus rhythm. Criteria for a normal sinus rhythm include a heart rate of 60 to 100, so a lot of variation, which is considered normal. So you can have a really fast heart or a relatively slow one and still be normal on the electrocardiograph. So we would expect anybody, when you feel the pulse and listen to the heart with the phonocardiograph, 60 to 100 would be considered probably done. Regularity, as we saw with our patient, is the heart regular? Yes. Okay? But her heart was regular, but she still showed an aberration on the s.a.node. And that's important, isn't it? Because we've got to get rid of that, because something's interfering with that. The s.a.node pacemaker, or pacing the heart, therefore the P wave must be present for every QRS complex in a ratio of 1 to 1. The PR interval is between 0.12 second and 0.20, and the QRS complex width should be less than 0.12. So looking at very small measurements on an electrocardiograph, so when it comes out as a stream on a piece of paper, this can be measured. Anything which is abnormal from those timings is potentially potentially a heart problem. But it's electrical. Okay, so the electrocardiograph really picks up electrical problems, okay, and not muscular problems. The phonocardiograph is much more important from a functional point of view of picking up functional problems, which is where we come in. We're not going to see or be expected, people are not going to come to us who've got severe cardiac pacemaker problems. or terminal parts of cardiac failure, they're going to come because they're beginning to feel tired, they may be getting breathless, they may be getting precordial pain. And this is where we may be able to help by nutritional and functional medicine interventions. So properties of heart muscle. So automaticity is most prominent in the s.a.node. In the s.a.node, if the s.a.node is destroyed experimental, the AV node takes up the duty. In this case, the heart rate is slower and the auricle and ventricles beat simultaneously. So in other words, we have an automatic process where it's nice and rhythmical. The rhythmical, under normal conditions, the heartbeat is regular, allowing for the heart rate variability. So remember, when we inspire, we go a little bit faster. When we expire, we go a little bit slower. If you don't do that and you have the same beats, regardless of inspiration, expiration, and normal respiration, you are apparently close to death. So a regular heart is not a good thing. Okay? It is normal to go up and down. Okay? But I would say you're probably not close to death, you've probably got a cranial fault. Okay? We probably wouldn't take it to that extent. But apparently it is absolutely normal, and you can see this on a heart rate variability, up and down, and hopefully nice and coherently. It looks a pretty pattern up and down there. If it's a straight line going along there and it's 72 all the time there, it means the heart isn't responding to the brain. Okay. Conductivity. Once a beat begins in the heart, whether it's at the s.a.node or some other point, the contraction is complete. So in other words, once it fires, and the whole contraction completes. Then you've got the resting period, which is called the refractory period, as we know, between the beats. And there's some argument about whether the muscle tissue in the heart has tone. So whether it has tone or not. It is defined as a sustained state of partial involuntary contraction. So muscle tone is when you feel a muscle and it feels nice and firm, but not flaccid. When it's flaccid, it's lost its tone, hasn't it? And this is the question of whether the heart muscle has tone in the first place. I often tell the story that years ago I had a patient who had a scar across here, and I said, "Oh, what's that from?" And they said, "I cut my finger with a bread knife and slipped, and it cut the extensor pollicis longus muscle here." And I said, "Oh, that's interesting. How did they get it back?" And they said, "Well, they got hold of the tendon where to zoom back to and pulled it up and then sutured it in some way." So I said, "Where was it?" She said, "Well, have a look at the arm." And they went up the arm, and there was a scar all the way up the arm until they found the tendon, and it was halfway up the arm. Okay? And I thought, oh, wow, because you don't think of living tissue in that state of contraction, do you? So in other words, there's a tone to that, which if you cut that muscle, it contracts, okay? It goes, springs right back. So they're really like elastics being stretched, really, really powerful, more like catapult elastic. So we don't see that in a dead body. When you've done dissection work, like we did for years, you see pieces of meat, and you cut through that psoas muscle, and you see a piece of meat, you know, a nice fillet steak and such. But what you don't realise is a fillet steak there, that psoas muscle is a catapult elastic. You could do a bungee jump on that. You know, it's that thick and that powerful, which really is. And then you begin to see what Dr. Goodhart's amazing discovery was: if a muscle is weak, you know, you can begin to see why a person's low back, if one psoas has gone weak or both psoas has gone weak, why they've lost all their support. Okay? So the importance of muscles are dynamic. And this is the question, is if the muscle, there was no tone, the heart would just balloon. Okay? But if there's too much tone, it won't expand. Okay? So they're still debating whether the muscle whether the heart has an inherent tone in that muscle or whether it's toneless. So to finish off this morning's work, I'm going to just look briefly at the supply of the heart, because this is where we lead on to other aspects. So we've talked about the accelerator and the brake. So really all we need to discover or discuss really today from the innervation point of view, in other words the nerve supply, is the ratio between the inputs from the parasympathetic and the sympathetic. So the sympathetic, all you need to know is speeds it up. It increases the heart rate and it increases the stroke volume. In other words, the contraction of the ventricles are much greater. So a person who's not contracting enough may have a sympathetic nervous system problem, and the person who's got a low contraction may have a vagus overstimulation. So the afferent system, in the past, attention has been directed almost entirely to the efferent fibres of the sympathetic fibres. In other words, the efferent coming into the heart, but now we recognise that it's afferent. Even the sympathetics are afferent. So the heart is feeding information back to the brain through the sympathetics and the parasympathetics and creating a complete modulation continually. So this can be overridden by mental activity. So if our heart brain is out of concurrency or out of coherence, as they call it, and we're operating a particular program which is very stressful in some way, we're going to be in an excited state all the time, and the coherence will be all over the place, as we'll see in the phonocardiograph. So we can whip through these because we basically said that. So stimulation of a nerve or other organ is brought about by an increase in the number of impulses which affect the nerve or organ. So in other words, the amount of input to that nerve depends upon the stimulation of the nerve, and that stimulation of the nerve at the end, whether it's afferent or efferent, depends upon the neurotransmitter or the chemicals. And the question is, where do those chemicals come from? And the answer is they have to come from inside the cell. So it could be that the information coming back to the brain through the sympathetic parasympathetic comes actually from the cardiac muscle. So what's happening in the cardiac muscle is sending information to the brain. So if that cardiac muscle says, I'm hypoxia, I haven't got enough oxygen, or I'm not producing enough ATP, it'll send that information to the brain. So the brain will send information back through the sympathetic, say, well, let's open up the tubes, okay? We need more blood to the heart, so let's increase the heart rate, or let's increase the contraction of the heart, okay? So it has to feed back. If it doesn't feed back because you've got a mechanical obstruction or there's something in there which is toxic, you won't get that feedback mechanism. So most of the time when people's blood pressure goes up, it's because they're not getting enough blood to the head. But it's not the blood, it's the oxygen and the nutrients, but it primarily is oxygen. So what's happening is the heart is being instructed, beat harder, okay? Let's increase this blood pressure in order to get oxygen up to the head, okay? So it's an adaptation to a problem and not the problem itself. So we said that impulses from the brain increase the heart rate. Contraction of the voluntary and involuntary muscles and mental activity influence the heart rate and these organs. There's no doubt that it is the afferent fibers of the vagus and the sympathetic system, in other words, the information to the brain, impulses which produce pain and other reactions known as angina pectoris when we don't get enough oxygen to the muscle tissue. Impulses conveyed by the afferent nerves affecting the vagus decrease the heart rate. So remember, the vagus slows it down, especially the left vagus, as in certain affections of the bowel, when impulses arising from it produce a slowing of the heart and syncope, the so-called vaso-vagal reaction. So in other words, when you get the wind in there, you stimulate the vagus and down goes the heart rate, and then you faint. So sympathetics, vagus, and sympathetic and parasympathetic through the vagus. So we went through that because we talked about that. When there is an abnormal rhythm, as in fibrillation or flutter, this would be atrial fibrillation or flutter of the auricle, then they then act upon the AV node. So impulses, when you've got an abnormal fluttering of the heart, this is more an AV problem. Usually the SA is knocked out. So when the AV comes in, it causes an abnormal type of rhythm. Okay? So when the AV is working and the SA is defunct or decreased in its function, you get the fluttering or the fibrillation. So there is no perfect regulation and control of the contraction of the ventricle, which is exercised by the s.a.node. However, the afferent fibers of the sympathetic and vagus are in direct communication with the muscle cells through the impulses. The pass out of the muscle cells, that the great complex of symptoms including the term angina pectoris. So this is a good time to just review. So what we have is an inherent rhythm, bum, 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 bum. Okay, so we're all happy with that. We can normally speed it up and slow it down by inspiration, expiration, which is perfectly normal. But we can speed it up considerably by activity of the sympathetics. We can slow it down by activity of the vagus. So those of us in mechanical work, osteopaths and chiropractors, know the importance therefore of thoracic lesions. somewhere where the sympathetics would come from, could inhibit our sympathetics, or could, in theory, excite them. Okay? And very frequently, the vagus nerve. So the vagus nerve can be inhibited. And very frequently it is inhibited by lesions or subluxations, whatever you want to call them, of the occiput to the atlas. So this is the key bit. Now it's very difficult to get this to show, because you do need to be able to tuck the chin in, okay, to bring the posterior arch of the atlas out for therapy localization. Many people miss lesions, lockings or whatever, between the atlas and the occiput because they therapy localize like this, and they say, no, it doesn't do it. But when you tilt the head forward and then therapy localize, you'll often get the posterior arch of the atlas to show and to therapy localize. Now, when there's a problem there, it can push on the vagus nerve as it comes through the foramen. And if the vagus nerve is inhibited, what you do is you take the brake off. Now, if you take the brake off, it means the accelerator is going. Okay? And the accelerator is governing then over the normal inherent rhythm, so up goes the heart rate. But then that person is in a stressful state for whatever reason. It could be emotionally stressed, it could be something you've eaten, it could be a car's coming towards you, whatever it is, and bang, 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 the heart starts and it won't stop. And that's called paroxysmal tachycardia. Okay? So many people have learned that if they stimulate the parasympathetic nervous system, they can slow it back down. Some people do it by deep breathing, some people do it by prodding on the eyes, and other people prod, somewhere in the neck and things. So you learn sort of ways of being able to reduce the bum, 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 the tachycardia. So fast heart rates and slow are modulated over and above the normal by the sympathetics and the parasympathetics, which can be mechanical, but it can be biochemical. And it can be emotional. So when it's emotional, it tends to obviously be brought on when there's an emotional problem. When it's biochemical, it's more consistent. And when it's mechanical, it's when the person changes posture or position. So if a person gets it every time they stand up, when they sit down, when they lie down, in one position, but it goes off in another position, they tilt the head forward or whatever, that's mechanical. Okay? If it's consistent all the time, for long periods of time, that's biochemical. Okay? So it could be a toxin, could be something you've eaten, drunk, could be a deficiency. And if it's worse when you're stressed, then stress, obviously, the emotion has a big part to play in this.